Hi, this is Ahmed Alogaili and Manos Brilakis, presenting case 245 for the Manual of CTO Interventions. This is a case of a failed attempt to recanalize an ostial circumflex CTO. The patient was an elderly gentleman who presented with dyspnea on exertion that was considered to be his angina equivalent. He did have lateral ischemia, slightly reduced ejection fraction, and was found to have a circumflex CTO on both coronary and CT angiogram. The coronary CT does show the occlusion of the circumflex, but also shows severe calcification of the left main at the origin of the circumflex. This is a coronary angiogram. Again, heavy calcification, ostial occlusion of the circumflex. There is a ramus branch, and there is filling of the obtuse marginal through epicardial collaterals coming from the ramus branch. And in another view, again, there is an ostial occlusion of the circumflex. So to summarize, what we have here is a semi-ambiguous cap. You have the calcium here that shows the location of the circumflex, but it is unclear exactly where is the proximal cap, the entry into the occlusion. We do have the ramus next to the proximal cap. The length is relatively short. There is good retrograde filling almost all the way to the occlusion. The distal vessel seems to be of good quality, and the distal vessel is filling through epicardial collaterals from the ramus. So our plan here was to try undergrade wire. If that failed, try ADR, and if that failed, try retrograde through the epicardial collateral from the ramus. We try to do intravascular ultrasound, but as is often the case with severe calcification, we actually could not see behind the calcium. So it was very hard to accurately localize the location of the proximal cap. This is the guide wire that is into the ramus branch. So if we go more distal, we can see that because of the severe calcium, it's unclear exactly where the circumflex CTO is starting. We did attempts to wire the circumflex CTO. We used initially a Sasuke dual-lumen microcatheter, but this did not really help. And then we tried a Venture, which unfortunately is no longer manufactured. This is an angulated microcatheter that has a tip that flexes by rotating a proximal knob, and that provides very strong support, but unfortunately we were unable to really make much progress into the occlusion. After trying several guide wires that were not into the occlusion, this wire seems to be outside the vessel architecture, including the Confianza Pro 12, Gaia Next, and Horner 14. We tried once again with another angulated microcatheter, the Supercross, but this also was not successful in helping us cross through the occlusion. So after multiple failed attempts, the question was about whether we should attempt to go retrograde, and we decided to explore the option further. So we inserted a Kerovel and did a tip injection. We see that there is an epicardial connection. It is relatively small, and this is when we had a lot of discussion during the procedure whether it's worth taking the risk of potential puncture of the collateral. Eventually we decided to try it. We used the SUO3 soft 0.3 gram guide wire, and the wire was able to find its way to that connection, and then eventually with a very gentle rotation, after quite a few attempts, once again with the SUO3 very soft guide wire, we were able to redirect the guide wire, which found its way across the collateral, and now it seems to be free going along the course of the circumflex. And sure enough, once it was advanced, it is now at the distal cap of the CTO. We were able to advance the Kerovel along the epicardial collateral all the way to the distal cap. So now we have established our distal base of operations, having the microcatheter all the way back up, and then tried several guide wires in an attempt to puncture into the left main. However, we had a lot of difficulty, although the guide wires seem to overlap. In reality, what happened is that the retrograde guide wire went into the extra plug space into the left main. And of course, remembering the left main, this makes sense in a way. There is such severe circumferential calcium into the left main that the guide wire cannot penetrate it, so instead it's going extra plug around the left main. And this is where we had a lot of discussion about how aggressive we should be. One option here would have been to try to puncture and get extra plug into the left main a little more proximal to the bifurcation. But this meant that we put in danger both the LAD as well as the Ramos branch in this elderly, in his 80s patient with slightly reduced ejection fraction. So after multiple attempts, we decided that it's not worth to attempt that. The risk we considered was too high, and we decided to stop. We checked the epicardial collateral, and fortunately there was no perforation or no dissection, and the procedure was aborted. Several lessons from this case. The first one is that when having a difficult to determine proximal cap, IVUS can sometimes help. However, if there's severe calcium, IVUS may not be very useful. But another way to resolve the ambiguity is to go retrograde, as we did in this particular case. How to cross into an ostial CTO that starts with an angle. So the ostial circumflex is the classic example of a branch ostial CTO that comes off at an angle from the left main. We tried several techniques here, including using a dual lumen microcatheter, a Suzuki, that provided more support, but we could not penetrate. The same by using two angulated microcatheters, the Venture and the Supercross. Despite the strong support with the Venture, we were not able to puncture. And the reason for that was the heavy calcium. Crossing epicardial collateral. This is a high-risk procedure, so reserved when other things fail, especially in a case like this. We were able to successfully cross it, but we did use a very soft SUO3 guide wire to minimize the risk of complications. Finally, calcium is obviously the problem here, and it came down in the end to a question about risk and benefit. Yes, we did want to recanalize the CTO, but at the same time, we were highly concerned what would have happened if we potentially compromised the LAD in the left main, which might have happened if we dissected around the left main and went extra plug. So in this case, we decided to abort and avoid any serious complication.